Urethral cancer background. Females are more affected than males. Clinically involved lymph nodes are almost always pathologically involved as well, unlike penile or anal cancer. Workup H&P, do a DRE. Imaging, get upper tract imaging of the collecting system with a retrograde urethrogram to look for urethral defects. Also get a chest x-ray. Get an MRI of the pelvis and a bone scan if clinically indicated. Labs, CBC, CMP, PSA, renal function tests. Biopsy, cystourethropy, always biopsy nodes. Staging, T-staging, T1, subepithelial connective tissue. T2, corpus spongiosum, prostate, periurethral muscle. T3, corpus cavernosum, beyond prostatic capsule, anterior vagina or bladder neck. T4, other adjacent structures. End stage, N1, single node less than or equal to 2 centimeters. N2, single node greater than 2 centimeters or multiple nodes. Management, TIS, TA or T1, TUR with 2 centimeter margins followed by BCG. T2 to 4, N positive. Option 1 is neoadjuvant chemo-RT with 5-FU, mitomycin followed by surgery. 2 is chemo-RT alone. Prostatic urethra gets a urethrectomy plus cystoprostatectomy. Male pendulous or bulbar urethra is going to get partial penectomy or distal urethrectomy if possible, otherwise urethrectomy and cystoprostatectomy. Margin positive, attempt to re-resect or treat with chemo-RT. Technique, EBRT, volumes, primary nodes, inguinal and pelvic. Dose, whole pelvis dose is 45 gray. Primary tumor plus 2 centimeters involved nodes get 66 gray. Brachytherapy alone, you get 60 gray LDR. Boost after EBRT is 15 gray, 60 gray LDR. Toxicity and follow-up, perineal skin reaction is the limiting factor for EBRT. For renal cell carcinoma, pathology background, adenocarcinoma, 80% are clear cell, associated with von Hippel-Lindau disease. Syndrome, workup, H&P, hematuria, flank pain. Imaging, CT abdomen, pelvis, or MRI abdomen. Chest imaging, bone scanner, brain MRI if clinically indicated. Labs, CBC, CMP, urinalysis, consider urine cytology, and biopsy. Staging, T-staging, T1 is limited to the kidney less than or equal to 7 centimeters. T2 is limited to the kidney but greater than 7 centimeters. T3 involves major veins or perinephric tissue. T4, Gerotis fascia, ipsilateral adrenal involvement. End stage, N1 is regional lymph nodes. Management, stage 1 to 3 get nephrectomy. Adjuvant chemo for PT2 to T4 or node-positive disease. Radiation is not part of NCCN guidelines, only for palliative mets or brain mets. Adjuvant radiation has not shown benefit even in patients with node-positive disease or incomplete resection. ESMO 2016 IROC Consortium Clinical Practice Guidelines can consider SBRT for non-surgical candidates, meaning those who are unresectable or medically inoperable. There's a 7.8% local control, grade 2 or 3 toxicities, 1.3%. I would try to avoid giving radiation on the boards. Very low numbers of patients in these studies. Stage 4 or advanced get nivolumab plus ipilimumab, has better overall survival than sunitinib based on a study in NEJM 2018. Techniques and constraints, SIM, CT, supine arms up, SPRT dose per Demirler, Lancet Oncology Review in 2014, 40 gray and 5 fractions. Toxicity and follow-up outcomes, local recurrence after nephrectomy is 5%, hence limited role for adjuvant radiation or chemo. Higher, approximately 20% for R1, R2 resections or lymph node positive disease.